Good morning, my dear students. We are moving to the part 3 of the Adrenergic Pharmacology. So far we have completed the part 1 and part 2. With the part 1 and part 2 we have discussed something like the concepts of adrenergic receptors, neurotransmitter, its synthesis, storage, and various actions of the endogenous catecholamines like dopamine, adrenaline, noradrenaline. And after that, we have discussed the classification. There are two classifications we have already discussed. One was based on the receptor specificity. Then the other one is direct, indirect, and mixed one. Fine. We're moving to the part 3. Part 3 is about, we'll be discussing about the effect of sympathomimetic or adrenergic drugs on various organ system in the body, because we have seen that there are different receptors located in the different sites in the body, viscera, nerves, and all those parts. So definitely stimulation of these nerve system may have diversified effect. So we'll be looking to that aspect. Then we'll be discussing about one more classification, that's about the classification based on the therapeutic action or therapeutic indication. All right, so this is what we are going to discuss under part 3. So we have already discussed something called indirect sympathomimetics, and there were different forms of indirect sympathomimetics, like drugs which enter into the synapse, enter into the vesicle and displace the stored neurotransmitter and thereby increase the availability of this neurotransmitter, or those drugs which block the norepinephrine transporter so that it can increase the availability of norepinephrine. Or one more was the MAO, monoamino oxidase, and COMT, catechol or methyl transferase enzyme inhibitors, so that again the neurotransmitter level can be increased. That's the reason it is called indirectly acting sympathomimetics. Fine. So catecholamines are basically synthesized and recycled transmitter. An agent that inhibit catecholamine storage in vesicles can have two effects. Short term, the agent can increase the net release of catecholamines from the synaptic terminal and thus mimic sympathetic stimulation. So this is what I have discussed. See, those drugs can enter into the synaptic vesicle. There it can displace the stored neurotransmitter and release the neurotransmitter into this. Actually, vesicles are being depleted due to the effect of the indirectly acting drug, the displacing drug. Gradually what happened, there won't be any neurotransmitter to act according to the action potential. So in short term, it acts as an indirect sympathomimetics by promoting the level of neurotransmitter in the synapse, and the long term, since it causes depletion of the stored neurotransmitter, and eventually it acts like a sympatholytic. Okay, that's what I have mentioned, sympatholytic. I hope you got the concept, like how an indirectly acting sympathomimetic acts as a sympathomimetic in the short term and sympatholytic in long term. And now moving on to the effect of these sympathomimetic drugs. So here I doesn't mean that it's only about the directly acting or indirectly acting. What will happen? What will be the net effect of the drugs which are acting on this area? First one is CNS. As you know that we have a blood-brain barrier which is strict and which contain various enzymes, and COMT, monoamino oxidase, are also rich in this area, which may cause or which may restrict the entry of catecholamines into brain. Amphetamine have a spectrum of stimulant effects, beginning with the mild altering or reduction of fatigue, So before that, I just want to tell you, I have mentioned sympathomimetics, which can cross blood-brain barrier. Example, amphetamine, because these drugs are basically known as CNS stimulants. So by default, being a CNS stimulant, it has to cross blood-brain barrier. So it is not subjective. It's not the subject for monoamino oxidase and COMT. All right, that's the meaning of this sentence. So what happened once the drug enter into the brain, it can cause mild alteration or reduction of fatigue, progressing to anorexia, euphoria, and insomnia. And these effects probably reflect the release of dopamine in certain dopaminergic tracts. And I told you that dopamine is known as neurotransmitter of happiness. So definitely it can have some euphoric effect also. Indirectly, it can increase the release of dopamine. Repeated dosing of amphetamine results in the rapid development of tolerance and dependence. See, amphetamine is actually a mixed acting drug. Especially this is an indirectly acting drug which displays the storage of neurotransmitter from the vesicle. And what happened? Continuous use may deplete the stored neurotransmitter from the vesicles. Okay, so that's why once the stored neurotransmitter is depleted, it can lead to tolerance and dependence. So amphetamine is an agent. Gradually, frequent administration may lead to tolerance and dependence. I hope you remember the two terms, what is tolerance and what is dependence. This is being discussed when we discussed about the adverse drug reactions. Hope you remember. Physical dependence and psychological dependence. And tolerance. What is tolerance? So the CNS effects reflect the amplification of dopamine's action, the ventral tegmental area and other CNS nucleus. Not very important. Eye. So CNS is over. Next is on the eye. Pupillary dilator is innervated with the alpha-1 receptor. So any drug which stimulate alpha-1 receptor causes mydriasis due to the contraction of the dilator pupillae muscle. Contraction of dilator pupillae muscle. It is also called radial muscle and it causes mydriasis. Accommodation is not significantly affected because the ciliary muscle is contain muscarinic innervation or the parasympathetic innervation. In fact, the ciliary muscle contain only parasympathetic innervation, no sympathetic. Aqueous humor outflow may be facilitated by non-selective alpha agonist with a subsequent reduction in intraocular pressure. See this trabecular meshwork and the uveoscleral outflow. You will discuss this when we discuss about glaucoma and other aspects. So this may be affected or outflow of aqueous humor may be increased, hence the intraocular pressure may be reduced. Alright, and here I wanted to tell you this alpha receptor is alpha-1 receptor where the dilator pupillae muscle, and one drug which is exclusively used for the ophthalmology purposes, phenylephrine for mydriasis in ophthalmology, especially in fundoscopic examination, where we don't have to go for cycloplegia. All right. So as I told you, it promote the uveoscleral drainage system. We'll explain what is uveoscleral when we discuss about the glaucoma. Alpha-2 selective agonist. Example for alpha-2 selective agonist is clonidine, which reduce intraocular pressure apparently by reducing synthesis of aqueous humor. So the aqueous body is responsible for the aqueous humor secretion. So there alpha-2 receptor may reduce the aqueous humor secretion, same like a beta receptor also. There are beta receptors. One example, apraclonidine is a congener of clonidine which is used in glaucoma because it reduces the aqueous humor secretion. Now in the bronchi, you are seeing that beta-2 receptors are rich in bronchi. Beta-2 receptors, and it causes bronchial relaxation or. most efficacious and reliable drugs for reversing bronchospasm. You all know well that people use orally or meter dose inhalation or in nebulizer. There are various or even parenterally there are various strategies for the uh, use of salbutamol. Depend on the condition. If it is acute, you may go for meter dose inhaler, and if severe congestion, you may go for nebulization. Depend. And in GIT, it is well endowed with both alpha and beta receptors. So we have seen that there are alpha 1 receptors, alpha 2 receptors, and beta 2 receptors in the intestine. Then, of course, in the other part of gastrointestinal tract, located both on smooth muscles and on neurons of the enteric nervous system. Okay, activation of the either alpha or beta receptors leads to relaxation of the smooth muscle. Both you have seen that both alpha and beta receptor stimulation leads to relaxation of smooth muscle. And alpha 2 receptor may also decrease salt and water secretion into the intestine. Water secretion into intestine. Now, what is the effect on genitourinary tract? We have seen the alpha receptors in the bladder, especially in the sphincter of the urinary bladder. I hope you remember where the sphincter is located. Apart from sphincter and trigone also contain alpha 1 receptors. These receptors mediate contraction of the sphincter. Contraction of the sphincter. Mediate in men, alpha 1 receptors mediate prostatic smooth muscle contraction. So, in elderly, any prostatic enlargement which leads to hindrance of urine flow, that's generally called as benign hypertrophy of prostate. So generally it is addressed with alpha 1 receptor blocker like tamsulosin. We will discuss all those things. These drugs are sometimes used to increase sphincter tone. And beta 2 agonists may cause significant uterine relaxation because you have seen that there are beta 2 receptors on the uterus and causes uterine relaxation. And as a drawback, the dose of our beta 2 agonist required also cause significant tachycardia because this high dose of beta 2 agonists produce vasodilatation, maybe fall in BP, reflex tachycardia. That's the main reason. And serious phenylephrine or other selective alpha 1 agonists contract vascular smooth muscle. You know that vascular smooth muscle contain alpha 1 receptors. And in skin and splenic blood vessels is where an increase of peripheral vascular resistance and venous pressure. Why the skin and splenic blood vessels? Because this area, these blood vessels are rich in alpha 1 receptors, whereas the area is like skeletal muscles, the blood vessels supplying to skeletal muscle rich with beta 2. Okay. And therefore, this area, the peripheral vascular resistance increase and venous pressure also increase. These drugs increases blood pressure. They often evoke a compensatory reflex bradycardia. Of course, there is a alpha 2 agonists like clonidine causes vasoconstriction when administered IV or topically like nasal spray. But they're given orally, they accumulate in the CNS and reduce sympathetic outflow and blood pressure. Because you have seen that alpha 2 receptor is an autoreceptor and stimulation of this autoreceptor inhibit release of further release of neurotransmitters. Therefore, it inhibit the vascular tone from the brain. Therefore, it can cause reduce the blood pressure and use clonidine is used in clonidine is the selective alpha 2 agonist which is used all this renin secretion by beta 1, insulin secretion by beta 2 and glycogenolysis by both, especially beta 2, not both. Transport of glucose out of the liver is associated initially with the hyperkalemia. And what happened? Beta 2 agonists eventually increase the intake of potassium into the cells, resulting in later hypokalemia. So whenever we talk about beta-2 agonists, you should understand that long-term use of beta-2 agonists, systemic use of beta-2 agonists can precipitate hypokalemia as an adverse effect. So please remember, all beta agonists appear to stimulate lipolysis via beta-3 receptors. You are well aware about that because beta-3 receptors are there in the now this is the net effect. This is again you can note down effect of phenylephrine, skin splenic vascular resistance because alpha 1 receptors which is increased, skeletal muscle meager effect because mainly there we have beta 2 receptor. Renal vascular resistance also increase, so it can increase all, and as a result of increased peripheral vascular resistance, eventually BP may increase, so there will be a reflex bradycardia. Heart rate will be reduced. As far as the beta 2 agonists are concerned, consider no effect on the wherever the alpha 1 receptors are there in the skin, splenic vessels and all. But you know that beta 2 agonists can act on the skeletal muscle blood vessels and produce dilatation. Renal, no effects because no receptor. Mean blood pressure is decreased because beta 2 cause dilatation. And here, due to fall in BP, especially due to fall in BP is due to vasodilatation may lead to reflex tachycardia. Norepinephrine, doesn't have beta 2 effect. Maximum effect on the heart and other blood vessels. Okay. Now we have one more classification which is about adrenergic drugs based on the therapeutic classification. Adrenergic drug classification based on the therapeutic classification. Sorry, based on therapeutic indication. Classification based on therapeutic indication or therapeutic classification of adrenergic drugs based on pressor agents. So definitely pressor agents will have a predominant effect on alpha 1 receptor. So we have noradrenaline, phenylephrine, ephedrine, methoxamine, dopamine, mefendermine. And when you consider all these drugs predominantly have alpha 1 effect. Cardiac stimulants, mainly beta 1 agonist. So adrenaline, dobutamine, isoprenaline, all these three drugs have beta 1 agonist or beta 1 action. Bronchodilators, which receptors? Yes, beta 2 receptors. Isoprenaline, salmeterol, salbutamol, formoterol, bambuterol, terbutaline. So this is all classification based on the therapeutic indication. See, bronchodilators are used in bronchial asthma, COPD, etc. Cardiac stimulants may be used in shock, heart failure, etc. Pressor agents may be again used as styptic or used in the conditions like some hypotensive state. Some drugs may used to improve the blood pressure during. Now the next one is nasal decongestants because there are alpha receptors on the capillaries of the nasal glands, and stimulation of these may cause excessive secretion and causes excessive nasal congestion. And nasal decongestants are basically these are the drugs vasoconstriction produced by the alpha agonists, reduce the secretion of the nasal glands. Phenylephrine, phenylpropanolamine, nafazoline, oxymetazoline, xylometazoline, pseudoephedrine. Out of this, oxymetazoline and xylometazoline is commonly used as nasal drops during the runny nose and nasal congestion. And all these drugs are used in locally. One more thing, like it can, though it is used transnasally for local purpose, it can be get absorbed from there because there you have got vast vascularity. From there, it can be absorbed and produced increased blood pressure. CNS stimulants. So definitely these drugs can cross blood-brain barrier after administration. Amphetamine, methamphetamine, dexamphetamine, methylphenidate, all these are the examples, and these are used in many conditions like excessive daytime sleeping, like narcolepsy, and then ADHD, etc. We'll be discussing those things. The next is anorectics. Anorexia. See, often it's a term very commonly used. Anorexia, nausea, anorexia. What is anorexia? Lack of appetite. So when do you use this anorexia as therapeutic purpose? For a therapeutic purpose, simple, to reduce the food intake. And when do you want to reduce food intake? During obesity. So anorectics are used in treatment of obesity, but none of these agents are currently used due to the adverse effects. Fenfluramine, sibutramine, fenfluramine. So these are the agents used as anorectics. And please remember, these are used once upon a time. These drugs were widely used by trimming clinics, which was mushroomed across the urban areas, especially in the metropolitan cities, where people lead sedentary life and eventually end up with obesity, and they may go for weight loss without much effort, and anorectics were widely used, but many reports of cardiac problem, cardiac arrest, and many other problem have arisen, and that is the reason why this is no longer used. Risk benefit ratio. Uterine relaxants and vasodilators. So these are basically beta 2 agonists. Okay, Ritodrin is a specific drug for the uterus. Isosuprin is also used for as a uterine relaxant, may be used in premature labor, threatened abortion, etc. Terbutaline, salbutamol are non-specific. When I say non-specific, it is not very specific to uterus. It can also act on. So that's all about the part 3. With the part 3, we have discussed the effects of adrenergic drugs on various systems, including CNS, GIT, cardiovascular, eye, then genitourinary, metabolism, hormonal effect, etc. Then finally, we classify the classify the sympathomimetics based on the therapeutic indication. So that's all about the